I call it countdown to launch because, as you're no doubt aware, April 1st, we will be launching several changes to the NCLEX exams, and that's NCLEX RN and PN, all around clinical judgment. So my job today is to make sure that you know what's coming. I'm going to go through everything, including why we're doing it, but also because we have the benefit of 2 hours, which I'm really grateful for. This will be an interactive session. At times, you'll be using the chat a lot to type things in, and you'll see how that goes when we get there. So before I say too much, I always have to do our legal disclaimer. I like to call this, if you see something, share something, though. What this is about, just like it was mentioned, you have colleagues who aren't here today who could use this information. You probably have students who aren't here today who could use some of this information. Please do share. That is my goal, is to get this information to as many people as possible. The red address at the bottom, that's the small print. It just means if there's anything you would want to sell that I cover. I'm usually not that good, but if you ever wanted to sell anything I'm doing here today, you'd need to ask permission at that address. Okay, with that, let's take a look at what's happening today. So, why is the test changing? We'll cover that. I'll give you some early history to this project and the work we've been doing that pointed us in this direction. What do the items look like? I'm going to spend a lot of time here. This is where I spend the most time because, in general, I think that's what educators really want to know. Let's get a very thorough, comprehensive look at the new questions that are being added to the exam. I mentioned we've got some bonus features due to our 2 hours today. Interactive item writing, you're going to be working with me to develop a clinical judgment case study. What else? Well, besides the questions, what does the whole test look like, right? For example, people used to ask me, will the whole test be case studies? Spoiler alert, no. But anyways, we'll take a look at that. Scoring, you may have heard that some changes are coming even to how the test is scored, with partial credit coming in April. We'll cover that. And again, I'll put you to work a little bit in the chat box, scoring some next generation NCLEX items. Finally, I've got some news from NCSBN. You may be up to speed and know it already, but if not, maybe it's breaking news for you. I also want to point you to some of the best resources that we make available. And then, as Randall alluded, we'll have time for questions at the end. All right, let's go right to it. So why is the test changing? I'm going to take you back 11 years now. I've updated my speech, I guess, right? It used to be 10 years, but here we are, 2023. 11 years ago, January 2012, we had a meeting of the NCLEX Examination Committee. Who is that? Well, it's 6 to 8 regulators. It's not NCSBN staff like Jason. It's regulators from around the country that actually have oversight into the exam and make sure that our team at NCSBN is doing the best we can to make this a world-class exam and do all the right things. So a question came from Jan Hooper. She was education chair for the Texas Board of Nursing. Her question to us is, the NCLEX measuring the right things? Sounds like a simple question on the surface. And on the surface, it would be tempting for us to answer, of course it is. That's why we do our practice analysis. The practice analysis is a scientific study that tells us exactly what entry-level nurses at the RN and PN level are doing daily, and then we try to put that on the exam. But there's a catch. It was actually a much deeper question. So I'm going to take you back to English class and give you this example. We'll say high school, if you like, junior high maybe. But anyways, any test, not just the NCLEX, but any test is really a combination of what you would like to measure and what you can measure. So English class, you might have had an English teacher who wanted to know if you could write a good essay, poem, short story. But if you gave that English teacher only multiple choice questions to put the test together, you weren't going to be writing any poems or essays or short stories. It just is what it is. Well, that's essentially what Janice was getting at, which was, are there things that we should be measuring or that we'd like to measure that we can't right now, but maybe we could later? And really what she was getting at was clinical judgment. We could have said, too hard, can't do it, impossible to measure. but we didn't. And so this was a very pivotal moment in the history of the NCLEX and even the history of our organization. Instead of saying, no, we can't do it, the answer was, well, maybe it is a good time to really think hard about what it would take and then see if that might be possible after all. Could take a while, but let's see. So anyways, two studies came out of that, literature review and something that we called the strategic practice analysis. And here you get 5 years of research in 5 minutes. Literature review findings, probably for those of you who've been in the classroom for a bit, something you already knew, even in 2012. Critical thinking, clinical decision making, clinical judgment. These weren't foreign words to educators. These were already part of your curriculum. These were things you knew were important, right? We weren't really measuring them hard on the exam, let's say, but you knew they were important and you were already doing things with them. Okay, some numbers out of the literature review. About half of new nurses involved in errors, with about 2/3 connected to clinical judgment or decision making, and only about 1/5 of employers were satisfied with the clinical decision making or judgment skills of their new hires. What did this all add up to? Well, again, something you probably knew already: clinical judgment, critical to patient safety and public protection. Certainly that's why Jan brought it up to us at that 2012 meeting. But a key phrase here is even at the entry level. So plenty of literature lets us know that clinical judgment can and should improve over time with experience. But a key finding from our research was that it cannot start at zero day one. Some baseline levels needed for that new nurse to practice safely and effectively. Okay, let's now jump to what I called our strategic practice analysis. Don't worry, your screen didn't go weird. It is a funny looking diagram. Some folks call it the spider web or dream catcher, but I'm going to refer to it as a clock. So a visual that was part of our strategic practice analysis is this. Let's picture from about midnight to 7 o'clock, you see 63 nursing skills, and you can think of these as things like therapeutic communication, any skill connected to nursing. And then from about 7 o'clock up to noon, you now see 41 nursing tasks. These 41 nursing tasks were the 41 tasks observed during this strategic practice analysis. And then, as researchers love to do, you can connect or draw lines or crosswalk the various skills and tasks that fit together. I'll give you a few examples. Typically, we found that a particular nursing skill was used in more than one task. I bet that doesn't surprise any of you in the audience, but 5 to 10 tended to be fairly typical, by the way. We can go around the clock and see essentially that same pattern most of the time, sometimes a little more, sometimes a little less. But now, skill 33, which is clinical judgment, almost everything. It turned out to be 34 out of the 41 tasks observed, meaning clinical judgment, not just something the new nurse needed on an unlucky day, let's say, but really something pervasive that informed just about everything that the nurses were doing. So we're going to jump to the conclusions. You're not supposed to do that, but here we go. Jumping to our conclusions. Number one, and probably again telling you what you already know and what you already knew even in 2012. Clinical judgment, important and necessary. Key phrase though for us, even at the entry level. The NCLEX is a measure, right? It's a test designed to figure out if even at the entry level, you're ready to practice safely and effectively, right? We're not necessarily testing how good will you be in 10 years or do you know what the most experienced nurses know? Not at all, right? It is a test of the knowledge, skills, and abilities required for safe and effective practice at the entry level. So that's a really key phrase for us. If clinical judgment were important and necessary only for the experienced nurse, it wouldn't have a place on the test. Okay, let's go to number two. Current NCLEX, 2012 or 2022, or even January 2023, take your pick. We've got some clinical judgment. Some of you maybe have seen or heard about questions that sound like this. which of the following clients should the nurse see first, right? This one, this one, this one, or this one, with descriptions of what's going on. So there's certainly clinical judgment there. We can say prioritization. Those fall into our, let's say, management of care category on the RN exam. But the point is, you can find some clinical judgment today on the test. However, it tends to be indirect. It wasn't the intentional focus of the test item, and it's not comprehensive. So more on that soon. Let's go to number 3. If we want a more direct, evidence-based measure of clinical judgment, and that's a key phrase. This is really what's going on with all the changes, right? Why are we making these changes? What are we trying to accomplish? Direct, evidence-based measure of clinical judgment. If we need that, well, we're going to need additional research. Here I am 11 years later, so we got that right. And presumably some new item types. I want you to remember English class, right? Here's the English teacher that wants the essay and only has multiple choice questions. Well, that teacher is going to need some new item types. That's where we were, right? In 2012, 13, 14, 15, etc. Well, we've got them now. You're going to see all that. Okay, so that's the early history, but I hope what I've given you there is also our rationale for why we're making the changes. We never change the test just for the sake of change. It's to accomplish something important related to patient safety and public protection. That's always what's behind every change. It's a lot of work, so we don't do it just for fun. Okay, anyways, before we jump into our clinical judgment measurement model, I want to just point out what you might see in the upper right-hand corner. It's a little mini thumbnail of one of our next generation NCLEX newsletters. We've been putting out these newsletters now for about 5 years, every 3 months, each time on a different topic. These are great resources. Anything that I cover today, we've got a newsletter about, right? And that newsletter, you can read it at your own pace. It may go into more depth. That's certainly the case with this topic, the clinical judgment measurement model. So I want to make sure you know that if you listen to me today and you say, oh gosh, he covered this a little bit, I wish I knew more. Well, we've got a newsletter. At the end of the presentation, I'm going to share links to make sure you know where to find all these things. Okay, let's take a look. Here's a diagram I bet some of you have already seen. I think, initially put it out as early as about 2016 in a research journal, but it evolved a tiny bit. And this version here that I'm showing you, copyright 2019, is essentially the final. It's been stable since then. It's the one that the exam is based on. So there's a lot here. The newsletter will tell you about all of the boxes and bubbles and arrows that you see on the screen, but we're going to focus on this layer 3. You can see each row essentially is identified as a layer. Layer 3 has these 6 boxes: recognize cues, analyze cues, and so on, all the way through evaluate outcomes. The reason I like to focus on this layer, and I think you'll be glad I'm doing it, is because key statement here, right? If you were multitasking, you want to hear this. Every clinical judgment item being written for next generation NCLEX is being written to one of these 6 boxes, right? So we see a lot of bubbles, boxes, arrows, etc. Every clinical judgment item being added to the exam goes with one of these 6 boxes. We're going to jump ahead a little bit. Think about the case study. You've heard about the case study that's coming to the exam. Well, it's got 6 questions. Guess what? 6 boxes here, 6 questions in the case study. Those 6 questions in the case study go with these 6 boxes in this exact same order. So these 6 boxes are kind of like your decoder ring to the entire next generation NCLEX, or at least all the new material being added to measure clinical judgment. Okay, we're going to make this pretty real. Here we go. We're going to look at the new items, and keep in mind those 6 boxes. We will revisit them quite a bit. It's really my major emphasis for the first half of our presentation. Okay, we'll start with the case study. And again, we've got a newsletter. We've got 20 plus newsletters. I will say this: if an educator ever comes up to me, and this does happen, and says, oh, I'm too busy to read all the newsletters, is there one or two that you recommend most? absolutely this one, top of the list. If you have time for no other material from NCSBN about the exam, this newsletter is the key because the case study is the single biggest change coming to the exam, and this newsletter really helps you understand it. Of course, I'm going to do that for you live here, hopefully help you understand the case study with the same amount of depth and clarity. We'll see, but if not, you've got the newsletter. Okay, so let's take a look. This is what a case study screen will look like for your grads. The print's a little small for my eyes and maybe yours too. That's okay. We're going to make it bigger pretty soon. But for now, I just want to walk you through the parts of the case study screen. The first part, case study screen 1 of 6. Think of that as the "you are here," right? This alerts your grads that it's a case study, right? And you can imagine as we progress through the case study, screen 2 of 6, screen 3 of 6, etc. So when this left-hand bar, I guess we'll call it, comes up that says case study screen 1 of 6, your grads need to be on high alert. It's a case study. Well, among other things, that means all the information that you need to read is going to apply to 6 questions in a row. Read it carefully. Don't skip it. 6 questions in a row based on this information. Where you see the 2, 3, 4, 5, and 6, that's all the information that the case study questions will relate to. And we call that collectively the scenario. So you'll hear me say the scenario quite a bit. The case study scenario is essentially all the information about the client and what's going on that we can ask questions about. Now let's jump to number 7, and that's the item finally, or the question if you like. So each case study screen, you've got a lot of information on the left, you've got the item on the right, and as we proceed through the case study, essentially the item on the right updates to the next question. All the information on the left stays there. It's there. You don't have to memorize it. You don't have to write it down. It follows you all the way through the case study. You never lose any of it. So before we blow this up a little bigger and see what it says, I do want to give you a little bit of a warning. Maybe that sounds scary, a warning. I'll give you a notification. How's that? Which is this. In this particular scenario, you can see 4 tabs of information: history and physical, nurse's notes, vitals, lab results, 4 tabs. That is not a magic number. You'll see later in the presentation a case study that begins with only 1 tab. Your grads could see a case study that begins with 5 tabs of information. So the 4 tabs you see here is not a magic number. And what's more, we can also have situations where you start with a certain number of tabs and a new tab is added along the way. Pretend here that we start out and we don't know lab results yet, but maybe 2 or 3 questions in, the lab results come in. Well, then a new tab would appear. So the key feature, right, because I've just told you the example you're looking at doesn't tell the whole story. The key feature, what you should take away from this, is that there's a lot of information on the left-hand side in the scenario, and we just organize it into however many tabs make sense, and that number of tabs can vary from case study to case study. You'll see that as we go through 2 examples. You'll also, as I point you to some additional resources that we've made available through our website, you can look at some other case studies, even beyond this presentation, and see some of the variety. Okay, with that, we're going to jump in. Here we go. Here's that scenario that we talked about, but now it's a little more readable. You will all need to bear with me. This is, I think it's, an important safety thing we do, right? You as nurses and me representing NCSBN. I've had so many people attend my Zooms from their cars, right? That for safety reasons, I like to read these screens rather than expect drivers to sort of multitask. So anyways, here we go. The nurse is caring for a 17-year-old male client who reports a recent injury to the left thoracic cage. History and physical. Client reports injuring left ribs after being struck by a mechanically pitched baseball in a batting cage last week. Significant bruising, feels lightheaded. Reports some intermittent pain in the left shoulder, denies shortness of breath, has some discomfort in the left lower chest when taking a deep breath. Reports feeling abdominal fullness, occasionally nauseous, no significant past medical history. Surgical history includes orthoscopic repair to the left shoulder for a torn rotator cuff last year. Hasn't felt well enough to attend baseball practice since the injury. One of the reasons I like to read this is because I know for those of you who just glanced at it real quick, especially experienced nurses, it might have taken you 5 seconds to skim it and you're like, okay, yep, what's next, right? But putting yourself in the shoes of your grads going to take the exam, they're going to probably read it a lot more slowly, right? And have to think a little bit more about what they're reading. And so when I read it aloud, I try to accentuate the idea that it really is a lot of information, right? At a glance, you might have taken it in quickly, but it's a lot of information. And there's more. So let's go to the nurse's notes. Patient appears pale, slightly diaphoretic, large amount of bruising noted along the left torso and over the LUQ of the abdomen. Patient's guarded, tenderness upon palpation, dullness to percussion over the abdomen. Slightly diminished breath sounds on the left, productive cough noted. ECG, normal sinus rhythm. We can look at the vitals. Blood pressure 90/50, pulse 116, respirations 24, temperature 97.8. For our Canadian friends, 36.6. And then oxygen, we've got 98% on room air. Lab results, there's a special bonus that you might notice already. I'll get to it. But anyways, hemoglobin is 9 grams per deciliter, hematocrit 27%, white blood cell count 19,000 per cubic mil. Notice now this final column where you see reference ranges or normal ranges for each of these lab values. This, by the way, is not just in this example. This will apply to the entire next generation NCLEX, and not just in the case studies. Throughout the exam, wherever a lab value is given, the reference range will be given as well. So that's a change you might not have known about. Why are we doing it? Well, one of the things was, as long as we're making all these changes to the exam with the case study, right? Well, what are we trying to do, right? We're trying to ensure safe and effective, practice-ready nurses, right, in the real world. So real world tends to be these days, as you know, when the lab values come, the reference ranges do too. So greater authenticity. All right, that was the scenario. Let's take a look now at the questions that go with it. And again, remember, each question we look at will hit one of those 6 boxes from the clinical judgment measurement model, layer 3, that I highlighted. So here we go. Which of the following assessment findings require immediate follow-up? Select all that apply. And we see a number of things here. I think I won't read them all, but you see 8 things. This probably looks to you like a select all that apply item, because it really is. It's just got extra choices. On today's NCLEX, how many choices? 5 or 6 in the select all that apply. For next generation NCLEX, we give it a new name. We call it extended multiple response, but you can still think select all that apply. However, how many answer choices? 5 to 10. 5 to 10 choices defines this item type. It is, I don't want to say the most common, but I'm going to say it is a very common item type that helped us in our measurement of clinical judgment, right? I mentioned new item types would be needed. Well, I think we didn't even expect when we came up with this one just how useful it would be. We use this one quite a bit, extended multiple response. Now, that's exciting, but let's talk about what we're actually measuring here. Remember that scenario that I read, right? The batting cage injury. If you were to count it up, I probably covered 80 to 90 discrete pieces of information, whether we're talking about an individual vital sign or something about the abdomen or breath sounds or something like that, right? There were probably 80 or 90 things. And as you know, for your grads as new nurses, if they are bombarded, maybe that's the right word, with 80 to 90 bits of information about a client, that can be overwhelming, right? What's important? Maybe all of it, right? But can they respond to 90 things all at the same time? Of course, is being able to figure out which things matter the most right now. What I just said there, which things matter the most right now, is literally the way every case study will begin. We're going to use the terminology recognized cues right? But if we had the decoder ring, recognize cues, it's all about which things matter the most right now. We might ask the question with different words, like you can see here, but that is how every case study will begin. First question always is, you read a whole bunch of stuff. What's the stuff you need to care about most right now? All right. For each of these, we have a mini poster suitable for framing. So I just showed you the recognized cues item. This just gives you maybe a little more appreciation of what it focuses on. I like that last bullet the most, what's of immediate concern. But part of that is sorting through all this information and saying, well, gosh, what's most relevant versus least relevant? What's most important versus least important? So educators, when I started doing these presentations, would say, Jason, we don't just want to know if our grads know what's important. We want to know if they know why it's important. Well, good news for you. We don't do that with the first question, but we do it with the second question. So let's jump to that. Second question of the same case study. Again, for your grads, that whole scenario, all that information, all those tabs are still there. We don't see them because I wanted to make the question bigger. That's all. Okay, which of the following potential issues is the client at risk for developing? Select all that apply. First thing I'll point out before we get into what we're measuring, same item type you just saw. I mentioned we use this one a lot. Well, here it is again, right? So which of the following potential issues is the client at risk for developing? What are we measuring here? Well, essentially, it's, hey, how about those cues that were important? Why do we care about these things? What could they mean? Why do they matter, right? We're essentially interpreting the cues or interpreting some of the data or findings about the client. And the word we like to use in our clinical judgment measurement model, it's that second box. We call it analyze cues, right? How do these cues, or sometimes I say clues, fit together and mean something? Why are they important? And that's always the second question in a case study, is doing some level of interpretation or analysis of the cues, findings, data, choose your favorite word, right? That help us understand what's going on or why they're important. Let's jump to the third question. The nurse is initiating the client's plan of care. Complete the following sentence using the list of options. We're going to see some prioritization going on here. The nurse should first address, and we've got abdominal pain, respiratory status, lab test results, followed by, and there's another menu with, by the way, the exact same choices. That won't always be true, but in my example, it is. So I've got one closed and one open just to show you how they look either way, but it'd be those same three choices. Item type, not something on today's exam, not even close to anything on today's exam. Brand new for next generation NCLEX. We were not feeling creative, so we'll call it a pull-down menu item, probably for obvious reasons. So in terms of clinical judgment, prioritization, I think, is evident. If I asked you to tell me in one word what we're measuring, it would be prioritization, I bet. Now, in our model, I'm going to throw you a curveball. Hopefully there won't be a batting cage injury from it, but I'm going to throw you a little bit of a curveball when I show you our poster. So that third box at layer 3, we call prioritize hypotheses, right? Which explanations are most or least likely? Which possible explanations are the most serious? Okay, so there might be some hypotheses, and we're kind of ranking them, choosing among them, evaluating them, etc. Well, that sounds like prioritize hypotheses. If we go back here, you may not see explicit hypotheses, right? But you definitely still see prioritize. Sometimes I describe this second way that we might go as we get to the third question of case study, more like prioritizing some aspect of the client's status. Now that's a mouthful to fit in one of those little boxes in our diagram. So we don't say that, but the point is, when we get to prioritization, you might have explicit hypotheses coming up here that your grad's going to need to think about, but sometimes really just think of the keyword as prioritization. The hypotheses may be implicit, right? In order to figure out where to prioritize care, well, there's probably some hypotheses that are guiding those decisions but you don't see them directly in the item. So that can happen with prioritization, with prioritized hypotheses. Okay, great news for the football fans out there. I'll switch sports metaphors. We've hit halftime in the case study. We've just finished the first three, so that's an achievement for us because I cover a lot, right? So we'll sort of pause here and reflect. We've just covered the first half of the case study, but I like to call out and distinguish the first half from the second half for another reason. This is unofficial. You won't find it in our NCSBN literature, even in our newsletters. But I think it's helpful for educators, and I think it may even potentially be helpful for your students or your grads. First half of the case study, something you may have noticed is there were no nursing interventions or actions. I don't want to say the nurse didn't do anything because we know that recognizing and analyzing cues is doing things, but it's, doing things up here, right? That is true of the first half of every case study. I like to call the first half of the case study the nurse as a detective, right? The nurse is looking at the cues or clues like a detective, getting a sense of what's going on, right? What's important? What does it mean? Where am I going to start? What might be happening, right? Sort of a think before you do, right? Nurse as detective. As we go to the second half of the case study, that's going to be much more focused on interventions, right? I got challenged one time, Jason, what job would you give the nurse? Kind of like detective in the first half. What's the nurse in the second half of the case study? I was stumped for a little bit, but finally I decided magician. The nurse will be using the nurse bag of tricks, interventions, and actions to transform the client from their current status to hopefully an improved status. We can think of a before and an after, right? Nurse as magician in the second half. So let's keep that in mind as we jump in to the second half. Fourth question in the case study, scenario, same as before, right? Nurse is speaking with the physician regarding the treatment plan for the client who was just diagnosed with a splenic laceration and left-sided hemothorax. A few of you in the audience are like, I knew that's what it was, right? Okay. But anyways, for each potential order, click to specify whether it's anticipated or contraindicated for the client. This, again, is a new item type for next generation NCLEX. We're going to answer this question in rows and columns, and whenever that happens, we call it a matrix or a grid item. So that's the item type, matrix item or grid item if you prefer. And how does it work? Well, probably self-explanatory. For these potential orders like echocardiogram, we would decide, or your grad would decide, is that anticipated here or is it contraindicated? And so on down the list. In this example, we've got 8 potential orders. There could be up to 10, but in this case, we've got 8 in this particular example. In terms of the clinical judgment measurement model, what's going on? Well, I'm going to give it to you in friendly language first, and then we'll use our official next generation NCLEX terminology. Friendly language, what's going on? Well, you can see it. It's really what kinds of things will help this client, right? What are our possibilities? In the clinical judgment measurement model, we call the fourth box generate solutions, essentially the same thing, right? What kinds of solutions can be helpful here? I'm going to pause a little and say that this clinical judgment skill, generate solutions, is often confused with the next one, which is called take action. So I like to give metaphors and analogies, right? It all goes back to English class in this presentation. So I'm going to give you one here. Sometimes people say, Jason, I didn't really get the difference between generate solutions and take action. Aren't they both about interventions? The answer is yes, they're both about interventions, but here's how they differ. Pretend, I know it's a virtual meeting, but pretend several of you wanted to get together and go to lunch when I'm all done, right? You might be thinking, well, where can we go, right? What would satisfy our needs for socializing and appetite needs, right? So you've got your client needs, what kinds of things would help. And somebody might say, well, I really like that catchy jingle in the Burger King commercials. It makes me want to go there. Somebody else might say there's a great place for pizza. Somebody else might say, you know what, there's a really good Indian place around the corner. Well, these are all things that could satisfy your needs, but you're not going to go to all of them. Remember that as we transition from this question to the next one, which is take action. Here, it's almost like brainstorming. What kinds of things could help? Well, maybe there's a bunch of things. We might not do them all, right? But we're just trying to figure out what kinds of things based on the client needs could be helpful, whether we do them or not. When we get to take action, I know I'm beating this one to death a little, but when we get to take action, anything we choose, we are really going to do. Okay, with that, generate solutions. We have a poster for it. I've covered it. It's all about what could help, but it's also what couldn't help, what wouldn't help, what might be bad to do, right? What should be avoided, right? Thinking through possible interventions and whether they'd be maybe positive, negative, or somewhere in the middle, maybe just ineffective. Okay, here comes take action. I hope I've set the table well. We recognize the item type, same one we've seen twice. The nurse has been asked to prepare the client for immediate surgery. So we're sort of drilling down on a particular intervention, prepare for surgery. Which of the following actions should the nurse take? Select all that apply. And in this case, if we check off, let's pretend, the first 4 boxes, it really means these aren't just ideas and we might do one of them. Now, if we check off the first 4 boxes, it really does mean we are going to do all 4. Going back to my where should we go for lunch analogy, well, pretend you all picked Burger King, right? And well, what are you going to get? Burger, fries, and a Coke, right? You're really going to get all 3. It's no longer just brainstorming. So that's take action. Take action just goes from sort of a universe of possibilities to the specific things that are going to happen right now. Okay, what does the poster say for take action? 5th box at that layer 3, 5th question in every case study. Well, it's all about implementation. We, in these bullets, give it 2 different words, which or how, right? Interrogative pronouns, if I go back to English class, 2 different ones. We can think of this either way. We can look at this and say, well, it's definitely which of these things are we going to do? Check, 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 right? But in a way, you could also treat this as a how, right? It is a how question. How would you prepare a client for immediate surgery? Well, the how is I would do these 3 or 4 or 5 things. But I want to elaborate a little bit more on the how and just give you maybe plant a seed for another way that a take action item could go focused on the how. So it says here, and it's true, the how is never just a procedure memorized out of a book, right? Where the book says, oh, if you're going to change the IV, first you do this, then you do this, then you do this, right? We're never, in the clinical judgment portion of the exam, we're never trying to test memorization. So I'll give you a different example. We mentioned my background is testing and math, not nursing, so my examples might not be solid gold, but maybe a starting point for you. So let's pretend in the cues, right? In the scenario, we have cues that suggest difficulty swallowing, and we have a client who normally takes pills orally for pain, right? Well, how are you going to deal with pain, right? If the pain pills maybe can't be swallowed. Maybe that's too easy. Maybe that's too hard. You tell me. But the point is, that's a how, right? That's a how, and it depends on the scenario. You got to think about it. You got to use judgment. It's not memorized out of the book. Okay, we are now ready to close out the case study. 6th question. Click to highlight the findings below that would indicate the client is not progressing as expected. Click to highlight. Brand new item type. If we click on a sentence, it lights up. It gets highlighted. If we click on another one, it lights up and gets highlighted. Take a quick sip here. There we go. If we change our mind, if we say, oh, darn it, you know what, I don't think I want to highlight that sentence. Oh, we can click again and it gets unhighlighted. But at any rate, What did we call this item? You'll never guess. Well, maybe you did. Highlighting item is the name of this item type. In terms of the clinical judgment measurement model, well, this is much like even in the nursing process, right? Ending in evaluation. We give it the name evaluate outcomes, but essentially, what are we talking about here? I mentioned the before and the after, right? Especially in the second half of the case study. We transform through the actions, the interventions, the bag of tricks, the client from their before state to the after state, which hopefully is better, but as you know, sometimes could be worse, right? Uh, and can we identify signs of improvement, signs of decline, things that went well, things that could have gone better, right? Evaluation. You know it without me explaining that to you. That's always going to be the focus at the end of the case study. So we've just covered the entire case study, 6 questions, and I want you to know the 6 questions are not random at all, right? They all have a very specific focus, just like the end is evaluation. The beginning was what stuff matters the most right now, and everything in the middle accomplished a very specific purpose as well. I'm going to summarize it now, and I'll use some different words in some cases just to help, to reinforce, to help you think about it a different way. So, case study, what is it? It is the biggest change coming to the exam. That's why I've spent almost half our presentation just going through one example, but it literally is the biggest change coming to the exam. Real world, right? I probably it wouldn't have been me. So let's say someone on my team or one of you probably could have written 6 pretty good questions that used only half of the information in the scenario, right? There's a lot of extra stuff, but guess what? That's real world. You know that, right? You walk in and here's 100 pieces of information about this client. Well, some of it you might not need at all. Some of it you can come back tomorrow on or come back and check in an hour. And some of it is like, oh my gosh, ooh, right now, I need to do something with this, right? So real world, what else? 6 questions. And literally, if you have no other takeaway from this entire presentation, other than one thing, I want it to be this. The case study isn't 6 random questions. It's 6 questions that each cover a different aspect of clinical judgment. That aspect is one of the 6 boxes in the clinical judgment measurement model, always in this exact same order. So, for you as educators, things like recognize cues, analyze cues, prioritize hypotheses, those might be comfortable terms. For your students, maybe, maybe not. So I like to give what I'll just call plain English. This is the decoder ring of the case study in plain, simple English. Every case study follows this exact pattern. First question, what matters most right now? Second question, oh, really? How come? What does it mean? Third question, and this can go a couple ways. We talked about a curveball here. Third question, prioritization. What do I think's going on, or where should I start? Second half of the case study, what kinds of stuff could help? Then what? Well, what am I going to do, or how am I going to do it? And then finally, how'd it go? That's every case study, not just the one we covered. Every case study follows this template. Okay, couple other details, right? Whenever I give one example, like I just did, it's easy to draw some conclusions that will apply to all case studies, but it's also easy to accidentally draw some conclusions that only applied to the one I showed you. So the case study that I showed you, I think was set in the hospital somewhere, right? Is that all case studies? No. Case studies potentially can be set anywhere that you would find an entry-level nurse, right? Could an entry-level nurse be working at a school, in the school nurse's office? If so, there could be a case study about it. Eligible content. Well, we saw somebody with hemothorax, splenic laceration. Okay, could we find maybe more psychosocial integrity, what we call our RN or PN04 client needs category, psych, right? Could we find that? Could we find labor and delivery? it can come up in the case study. But, right, before we panic too much that these things can really get crazy, always, always, always on the NCLEX, even the next generation NCLEX, we have to stay entry level, right? So if you think about an entry level nurse involved in labor and delivery, well, what are they doing? What decisions are they able to make there, right? In what occasions might they need to use judgment, right? We're not going to get carried away and ask anything that could happen with labor and delivery. It needs to, it's really confined by what's in the test plan. But the main point is, right, is it always somebody with a broken bone or a splenic laceration? Could it ever have some more variety? It definitely could. If it's in the test plan, it can be in the case study. Okay, we're going to do one together. You're going to be typing a lot in the chat. So here we go. I mentioned my spring 2020 newsletter on the case study. This is where I've borrowed this example from. So if you happen to have that newsletter right next to you, put it away because it has all the answers. But anyways, let's just jump in and here's what we're going to do. Here's a new scenario. Forget the splenic laceration and hemothorax. New scenario, brand new person here. This is the one we're going to write all of our questions about. I'll go ahead and read it quickly. And it starts with only one tab. That's why I chose it for us, because it makes our lives a little easier in presentation mode. The nurse is caring for a 78-year-old female in the ED. Nurse's notes, 10 o'clock. Client was brought to the ED by her daughter due to increased shortness of breath this morning. Daughter reports the client's been running a fever for the past few days and started to cough up greenish-colored mucus and complain of soreness throughout her body. The client was recently hospitalized for issues with atrial fibrillation, little tongue twister for me, 6 days ago. The client has a history of hypertension. Vitals, 101.1 on the temperature, 92 pulse, 22 respirations. Blood pressure, 152/86. Oxygen, 94% at 2 liters per minute with the nasal cannula on. Okay, upon assessment, breathing appears slightly labored, coarse crackles are noted in bilateral lung bases, skin slightly cool to touch, pale pink in tone. Pulse is +3 and irregular, cap refill is at 3 seconds, client is alert and oriented ×3, as you like to say, and the client's daughter states, sometimes it seems like my mother is confused. So again, quite a bit of information. It all fit on one tab, so that's convenient for us. And now we're going to do this Family Feud style. I don't know if we have fans of the show, depending on your age. Picture me as Steve Harvey, but not as funny, sorry, or Richard Dawson without the kisses. Anyways, here we go, Family Feud style. We've got our scenario on the left in case you needed to try to remember something. But how would we write a recognized cues item? Well, I've got a little bit of a template here. Drag the top 4 client findings that would require follow-up to the box on the right. So it's a little bit of a skeleton of an item. There's nothing in it right now. Thinking about our clinical judgment measurement model, recognized cues, what matters most? What matters most right now? Well, you're going to tell me in the chat, give me your vote for something that might make the top 4, right? Something you see in the scenario that you believe requires follow-up and really is going to make our top 4. What matters most right now? Go ahead and type it into the chat. And I'll be monitoring, and we'll see what kinds of suggestions we get. Okay, and all right, let's see. Are folks typing into the chat? I will admit, as I'm monitoring it, nothing's coming through. Sometimes that happens where I've got a little bit of a delay. Interesting. Okay, well, gosh, let's see. So what I'd like in the chat, if you haven't done it already, is something that you believe is a correct answer to this question, a top 4 client finding that requires follow-up.
Jason, some of the things that I'm seeing in the chat on this side, breathing labored, coarse crackles, shortness of breath, vital signs, the temperature, labored breathing, temperature of a 101, coarse crackles, cool skin, fever with green mucus.
Beautiful, beautiful. Okay, excellent. For some reason, I always have my phone out to monitor the chat, and for some reason, it is not doing it. I wonder, Randall, if you'd be willing to do me a favor, and as we go through more of these, just go ahead and read things off as people type them in. Would you be willing to help me with that?
Absolutely.
Okay, and if somehow my thing syncs back up, I'll let you know. Okay, so fantastic work, everybody. I was a little scared I'd stumped you a little too much or I'd lost my connection, but it sounds like we were going strong. So now, thinking like an item writer, we also need some wrong answers here. So go ahead and start typing into the chat something that wouldn't make the top 4. Maybe it just doesn't need follow-up at all, or maybe it's a, come back much later and worry about this. What's something out of this scenario that could be a wrong answer for this question? We're going to need 2 of them. Go ahead and type in 1 or 2 things that you think could be a wrong answer for us. And then Randall, let me know if you see things coming in.
I do. I see things
Okay.
coming in. Hypertension, patient alert and oriented, soreness,
Good.
capillary refill, pulse of 92, the pulse ox.
Love it. Okay, so
current mental status.
Fantastic. Okay, so great work, everybody. So we're going to go ahead and see what the item writer came up with. This is where I mentioned it's kind of Family Feud style, right? Number 1 answer. No, okay, we'll just look at them all at once. So the item writer went with these, right? So I heard from Randall a number of these mentioned already. One of the things I want to emphasize when I do this activity, if you type something into the chat and you don't see it on this list, it doesn't mean you got it wrong, right? In some cases, your suggestions might be even better than what this item writer went with. These are just examples of ways we could fill in an item like this. I want to point out 2 other things, though, about this item. I always encourage educators or aspiring item writers to think of the right answers first, and then think of the wrong answers, or distractors, we call them, right? It's just a way of being logical and organized as you progress through the item. Right answers first, wrong answers last. However, if all you do is copy over your answers into the question that way, your students are going to figure you out quick. They're always going to know the right answers are on the top, the wrong answers are on the bottom. So there is a necessary step if you're an item writer, which is you got to shuffle them, right? One of my favorite ways to do it, and you can see it right here, is shortest to longest, right? And that's going to mix up the right answers and the distractors. So just a quick item writing tip, always remember to shuffle them up at the end so you're not cueing or giving away or helping the students too much. So that's part 1. But part 2, I want to point out something that I really like that this item writer did. And that is the very first choice here, vital signs. You may have put into the chat blood pressure. You may have put in respirations, right? As an item writer, as an educator designing something like this, maybe for classroom discussion or informal assessment, you've got a lot of latitude, right? So I never want you to think that you just need to pick out an individual, really discrete thing from the scenario to make it your answer choice, because that's what the NCLEX would do. Don't think like that. Well, here's a good example. The NCLEX, the next generation NCLEX, is also allowed to sort of clump things together. Point being, if you want, you can just do vital signs. I think they did this again with characteristics of the cough. The cough was described, I think, a couple different ways. That could have been 2 different choices, right? Or just pick one of them and put it there. But instead, they clumped them together. It's kind of a neat thing. Do you have to do that? Nope, not at all. But can you? Yes, right? So it's just a matter of taste, but I want you to know that that option is always there. This item writer, I think, did a really nice job with that. At any rate, that was the first question. Let's go now to the second one. And again, you're going to help me fill in all the blanks. This is a very fun one. I dare say this is the fan favorite. for this exercise, but we need to do it in 2 stages. It'd be way too confusing to try to do it all at once. But what we see here, it's a matrix or grid because we've got the rows and columns that the answers are going to go into, or the answer, that the graduate would bubble in or check off. Well, we've got these headings, condition X, Y, and Z. I've covered them up, but the point is, think of them as conditions, disease processes, illnesses, conditions, etc. Any, choose your word. Things like COVID, for example, right? We want to come up with some that would be interesting. I don't need to say correct, right? I'm not saying the client has all three of these things, but would be interesting, right? When looking at the findings, when looking at the scenario, where we might say, ooh, might it be COVID? Because I see this and this. Ooh, but I also see this, right? Interesting to think about. So go ahead and type in, and Randall, I probably will borrow you again. Go ahead and nominate a condition, not necessarily that this person definitely has, but that at least some signs and symptoms might point to. Go ahead and type that in, and Randall, let me know what you see. I think I'm still a little behind with my version of the chat.
I am seeing pulmonary emboli, pneumonia, lots of pneumonia,
Okay.
influenza, sepsis, heart failure.
Okay. Okay. Some pretty serious things. And those, I've done this exercise with a few different groups, and those are things that we get a lot in the chat. This particular item writer, I think we heard all three of these. Pneumonia, I think we heard UTI, maybe not, but pneumonia, UTI, and influenza. So for the rest of this exercise, we'll go ahead and use these three just for things to make a little more sense. But again, remember, you have latitude, you have freedom. If you were trying to create something like this to work with your students, and you said, well, gosh, I wish I could have four because I want to do COVID or I want to do heart failure. That's okay. You just add an extra column, right? So I've got 3 columns or 3 conditions here, not a magic number. You could stretch it to have more. If you said, oh gosh, I don't know if my students are ready for 3 of them, I'm just going to have 2. You could do that too, right? Okay. Well, in this case, we got 3, pneumonia, UTI, influenza. Now what I'd like you to do is pick something out. I'll do one of them just to show you how it works, but you're going to pick out something from the scenario that would be interesting for your students or grads to consider as to whether it goes with pneumonia, UTI, influenza. It could go with none of them. It could go with all 3. It could go with only one, right? It could be anything, but something that would be interesting. So for example, if I chose shortness of breath, well, that's interesting. Could it go with pneumonia? Well, definitely. Could it go with UTI? Well, I confess to not knowing that answer. Influenza, I'm not sure either, but you all know, I bet, right? But that's how that part works. So go ahead and give me a client finding. Again, doesn't matter, doesn't have to go with all 3, doesn't have to go with any, but something where you'd like your student to be able to think about, does it go with pneumonia? Does it go with UTI? Randall, let me know what you see.
I see confusion. I see
Okay.
crackles, labored
Okay.
breathing, shortness of breath,
Okay. All
fever.
good ones. Good ones. Okay. So I think folks get the idea. In this particular item, let's see what the item writer came up with. Well, many of the same. And again, if you're working with students and you say, gosh, I have a 6th one that I would love to do, but there's only 5 rows, not a problem. Add a row, right? Or, oh, I didn't have my coffee. I can only think of 4 of these. Okay, not a problem, right? Cross out a row if you like, right? So anyways, fantastic. This is definitely an item type that people like. It's nice for analyzed cues because we've got all this information. Obviously, your grad isn't here to make the diagnosis, let's say, right? But your grad is certainly here to associate certain signs and symptoms with certain things that could be of concern. All right, let's jump to the third one now. Same scenario. We're going to have a little twist on the scenario later, not yet. So for now, same scenario. Complete the following sentence, choosing from the list of options. The client is at highest risk for developing something, as evidenced by something else. Well, let's start with the first part. The client is at highest risk for developing. Go ahead and type it in the chat. And Randall, let me know what you see.
Pneumonia.
Okay.
Sepsis.
Okay. Okay. And I will say when I do these workshops, it might be a tie, right? You can imagine for an NCLEX item, we don't want to have two right answers for something like this. We only want one. This is one I borrowed early for my presentations. Had not gone through all the reviews, so I will say it's debatable what the right answer is here. Some of you might say pneumonia, some of you might say sepsis, and I think sometimes I've seen other folks make impassioned pleas for yet a third thing. But at any rate, okay, we're focusing on kind of the logic of writing these, and so I'll worry a little less about that. But now, as you imagine this pull down menu being pulled down, right? We know we need a right answer. We also need some wrong answers. So go ahead and type in something that isn't totally out of left field, but that would be a wrong answer. The client's not at highest risk. The client's not at high risk based on this for developing X. Let me know some things that we could use as distractors here.
I see heart failure, bronchitis,
Okay.
urinary tract infection,
Okay.
pleurisy,
Ooh, okay. This may be a first.
pneumothorax,
Yeah, pleurisy.
bowels,
This may be my first one with pleurisy. Uh,
atropine.
okay. All good. All good. So now what I'm going to do, I'll show you what the item writer came up with. Hypoxia, stroke, dysrhythmias, and PE. And then I'll show you the second menu because I think it's kind of a clever one, and it'll help us kind of keep time for questions at the end. So I'll give away the answer. But at any rate, um, based on, again, remember I talked about that clumping, right? Grabbing a lot of things and putting it into a single choice. The item writer, I think, did a really neat job of that here. I like how they've got the vitals. They've clumped together all the neurologic stuff, all the respiratory stuff, all the CV stuff. I like that, right? It definitely keeps the answer choices a lot shorter. But I also like this item because I feel like the second menu of choices doesn't give a big hint as to what the first thing is. Sometimes this can be a tricky item type because as you write it and you fill in your second menu, okay, what's my evidence? Well, it's all pointing back to maybe one of the things in the first menu. So I like this. I feel like it doesn't give any hints. Second half of the case study, here we go. This one I think is another fan favorite. The matrix grid items, I think people enjoy working with. And when folks have told me they've used things like this just for classroom discussion, they find that it goes well. So let's take a look here. I mentioned a twist coming. The nurse has reviewed the nurse's notes entries from 10 o'clock and noon and is planning care for the client. So we have something new here. Noon, called to bedside by the daughter who states that her mother isn't acting right. Upon assessment, client difficult to arouse, pale, diaphoretic in appearance. I think I saw this plot line on Chicago Med. I'll be honest with you. I think they all go like this. You know, you get one way at 10 o'clock and then at noon. Uh-oh. Anyways, vitals. They've changed a little. Temperature 101.5. Well, pulse and respirations have changed a lot. 112 and 32. Blood pressure's changed a lot. 90/62. Oxygen holding steady, I think. Is it the same as before? Oh, no, it's not. It's worse. It's dropped. Okay, 91% now, still at the 2 liters per minute with the nasal cannula. Okay, generate solutions. Remember here, this is where we're brainstorming or thinking about things that could help this client. So let's start there. What kinds of things could help this client, right? Here we are at noon. Here's all this information. What could help? Type it in. Randall, let me know what you see.
Increase the oxygen, nebulizer treatment, blood cultures, fluid bolus,
Mm-hmm.
change oxygen delivery to a face mask, semi-Fowler's position,
Love it.
antibiotics.
Love it. Love it. Love it. Okay. All right. We'll press pause on that because, again, we want not just things that could help, but some things we wouldn't want to do, right? It'd be great if we had one or two things where somebody would bubble in contraindicated. So let's see if we can get one or two of those. And I just want to, I'll make a quick pitch here, right? Quick pitch. I'm still going with that baseball. My quick pitch here is when you're coming up with your distractors, in this case, when I think of contraindicated, I'm kind of thinking like as if they're distractors, right? The things we wouldn't want to do. You don't want to be too obvious. So for example, prepare client for discharge. Would you have any students that would think we should prepare this client for discharge? No, right? So that wouldn't be a great one, right? So you want things that maybe your top students would know, oh no, I don't want to do that, right? But you could picture some of your students thinking, oh yeah, maybe I would want to do that. Maybe this client's hungry, right? I don't know. Anyways, so go ahead and nominate one or two things that would be contraindicated for the client, but not super obvious. And Randall, let me know if you see anything.
Yes, ambulate patient,
Okay.
CT scan,
Mm,
insert a Foley,
yeah.
blood sugar,
Okay.
feed the patient, lower the head of the
Beautiful.
bed.
Great, great, great. I love it. I love, by the way, that we got the positioning of the client and we got the head of the bed in here because I think sometimes when I do these workshops, we get a lot of things that kind of ignore that aspect, and those are always great. There's always something right or wrong. It seems like with the head of the bed or the position of the client. So it's sometimes easy to forget those. But anyways, here's what the item writer did. All of you probably know which ones are indicated versus contraindicated. I'm not so sure that I do, although I bet yeah the oxygen flow. I knew that one, but okay. Uh, Perfect. And now let's go to take action. This one's a little bit interesting. The nurse has received, sorry, orders from the physician. Click to highlight below the three that the nurse should perform right away. Well, here we are at 12:15. We can see that there were 5 orders because I left the bullets, right? It's a bulleted list. I left the 5 bullets. So there's 5 orders. 3 of them we need to do right away. Well, this may feel a little bit like deja vu. Remember, I said that it's easy to confuse generate solutions, and take action, well, it's true. Sometimes there's some overlap. So it's okay if you give me some things that you already gave me for generate solutions. Nominate some things that the nurse should perform right away, some anticipated orders that have a right away status to them. Go ahead and type those in. And Randall, I think I will still rely on you.
Increase the O2, IV fluids, blood cultures,
Okay, I'm good with that.
labs.
Okay. And now what we're going to do, we're going to switch gears because again, we need wrong answers here. So if we think about getting 5 orders, 3 of them need to be performed right away. Well, what does it mean for these other 2? I'm going to say there's 2 flavors. One could be an order that you got a lot more time to worry about. You don't have to do it right away. You get to it later. But, right, as you know, sometimes there's orders that you need to question. So I'm okay with either. You can give me either of those as we do this next part, as we look for our distractors. Go ahead and type in an order that you might have received, but you're not going to do it right away. And Randall, let me know if you see anything.
Neurological consult,
Mm, yeah, oh, I like
consent,
that one.
consent for defibrillation, CT scan,
Good.
provide quiet room and bed rest, anticoagulants.
Fantastic. Fantastic. And I always like to emphasize as an item writer, right? As an educator, you have a lot of leeway. So in this case, right, click to highlight 3 orders. Pretend that you care about 4 things that need to be done right away. Well, you could change this. Click to highlight the 4 orders, right? Just change one of the change the item a little, or pretend there were only 2 things you could think of that had right away status. You could change the 3 to a 2, right? A lot of freedom there. Fantastic. The item writer gave us, and again, 3 of these are right away, 2 of them aren't, but they gave us a catheter, they gave us the antibiotics, they gave us the CT scan, they gave us the saline, and they gave us various lab tests. And I heard about some of these. Randall read off, I think, some of these from you in the chat. So good job. Something I'll just point out, right, in terms of item writing is let's pretend, and again, I apologize because I don't know if it's right or wrong, but let's look at the vancomycin 1 gram IV every 12 hours, right? Let's pretend that that's correct. Well, pretend it said 100 grams, right? Well, maybe that came because somebody wrote it down wrong or the writing was messy or they just weren't thinking right. So again, the point is if you've got a good one and you want to turn it into a distractor, you could change the 1 to a 100, right? And well, now it's not something to perform right away. It's something to question, right? Sometimes people say to me, Jason, I have trouble thinking of an order that the nurse would question. Well, just take a good one and change something about it, right? Like 1 gram to 100 grams, something like that. Uh, that'd be a lot, I think. But anyways, maybe 10 grams, you tell me, right? Okay, last one, evaluate outcomes. And I'm going to throw you a curveball yet again. So we can see the orders we might prefer to remember the client status because we saw the client at 10, we saw the client at noon. At 12:15, we received these orders. We did 3 of them right away, and we're now looking at the client again. Let's pretend it's 3 p.m., for example. I don't know what time it is. We'll say 3 p.m. Okay, well, it doesn't tell us in the scenario the client's, let's say, pulse at 3 p.m. We don't know what it is. So here we have to do a little bit of creative writing. We have to use our imagination. When we're evaluating outcomes, we need to picture that it's 3 p.m., right? That all these interventions have happened. Well, what's the client looking like now? So up to now, every time we're cooking up content for these questions, we are grabbing things directly out of the scenario. The one exception is evaluate outcomes. We're going to come up with something that's not in the scenario, but it's what we imagine the client might look like. Let me make that real. I'm going to use pulse. Okay. Well, the client's pulse was 92, and then at noon, it was 112. What do I think it is now? Let's pretend I think it's 122. Okay, that's fine. It could be, I suppose, right? That's what I'm going to put here. Pulse, 122. All right. That would be an answer choice. Notice I didn't grab it straight out of the scenario. I kind of extrapolated, right? What do I think it could be now? And as you do this, you can picture that the client got better in some ways, but maybe got worse in some ways. Maybe they got worse in all the different ways you want to go with, if you like. But anyways, so let's just give it a try. Picture that the client got a little better. Give me some things that we could put in, some assessment findings where you would want your grads to recognize, oh, that's a little better. Go ahead and type those in, Randall. Let me know what you see. So we're focusing on improvement, things that would be better than the 12 o'clock version of this client.
Respiratory rate 18,
Love
oxygen
it.
saturation 96%,
Love it.
heart rate decreased,
Okay,
decreased
I'll
shortness
take
of
it.
breath.
Okay. Very good. Very good. Let's pause there and I'm going to make a quick comment. So those are terrific choices. One of the cautions that I want to make, I get this in a lot of workshops, but we also get this from our item writers who come to Chicago or participate virtually, writing real items for the exam, right? Often somebody will type in for the assessment finding, improved blood pressure. Well, the problem there is it kind of gives it away when you think about it. Avoid the adjectives, right? You don't want to write improved blood pressure or pulse got much worse, right? That's a big hint for your students, right? So we would never do that. But if we want improved blood pressure, rather than write improved blood pressure, we might say blood pressure 118 over 71, something like that, right? So always stay objective, always just put the finding, but don't add any kind of judgment adjectives to it, right? Near fatal heartbeat. Don't do that, right? That gives it away. That's bad. That's worse. Okay, excellent. Now let's focus on declined, right? Let's picture some things that maybe get worse. Go ahead and type in some findings here where the correct answer might be declined versus this before version of the client. What would be some findings that suggest declined?
Pulse ox 87%,
Beautiful. Ooh, scary, but beautiful. Okay.
cyanosis, apnea,
Okay. All good. All good.
blood pressure
Okay.
78 over 52,
Very good.
temp
Okay. Let's
102.9,
We're going to take a look at what everybody says, as Steve Harvey likes to say, right? Respiration's 36, so that I think got worse, right? Blood pressure 118 over 68, maybe that's better than before. Pale skin tone, I think maybe we saw that before. Maybe it's about the same. We've got the pulse ox, 91 with the nasal cannula. We've got interacting with daughter at bedside. Now, what I want to talk about are two differences between my world with the NCLEX and your world, right? Where the stakes aren't quite as high, right? It might be informal assessment, it might be classroom discussion, right? Versus legally defensible exam. I want to talk about two aspects of this item that are important. First, let's talk about no change. I didn't ask you to give me any no changes. This is actually a pretty dangerous column for us at NCSBN with the exam because when we do things with clinical judgment, as you can imagine, things are a little more gray than when you're testing knowledge or applications of concepts, right? It can be a little bit gray. Well, what do we mean by no change? Let's take a look here. Temperature was 101.5. Let's say now it's 101.4. Well, is that no change? For practical purposes, I think, yeah, right? How's the temperature? Oh, it's about the same. Okay, darn, right? That's real life, right? Darn it, it's still high. Okay, right? But on an exam, if somebody said improved, right, and we marked it wrong, and they went to court, the judge might say, well, didn't it get better by 0.1, right? So really good column for classroom discussion, a little trickier for us on the actual NCLEX. So we will have many items like this that actually omit that column because it's a little bit dangerous for us. I think you see what I mean, right? Because if somebody really wants to split hairs, right, what we might think of as no change, well, there was a tiny, tiny, tiny change that somebody could say was a little better or a little worse. So that's one thing I wanted to point out. Another thing, same theme, legally defensible. Two changes I would make to this item. We see the pulse ox 91% nasal cannula. Well, that's what it was before, but there's a little bit of a problem, right? We look at that and we go, oh, no change, same as before. The thing is, before it told us 2 liters per minute. Here it doesn't tell us, right? So somebody might say, well, maybe now it's 4 liters per minute. So that's worse, right? Or maybe now it's 1 liter per minute. That's better. So it's a little vague. I would rather be more specific on the NCLEX, right? So if this went through all of the reviews, at some point we'd probably add to it 2 liters per minute, right? Or maybe we would add 3 liters per minute, right? And make it worse. I don't know. Final one, right? I'm beating this item to death. I like the item, right? I like the item, but I want to point out the legal defensibility of the exam sometimes requires that we split some hairs. Final answer choice, interacting with daughter at bedside. That's good. I'm going to say as nurses, as educators, there's probably a positive connotation. They're swapping stories. Mom, I'm so glad you're doing better. Me too. I hope I'm good enough to go to Carl's birthday party after. Yeah, that'll be great, right? That's what we picture. It's a positive connotation, right? But it's imprecise. Somebody could say declined, and we could say declined. What do you mean declined? And they could say, well, I'm picturing the mom shouting at the daughter, where am I? How'd I get here? Who are you? Right? And maybe that would be declined. So I would like to be more precise with this last answer choice. And I'm going to give you a technique that sometimes is useful, right? It's hard to describe in a single verb something that definitely means better or definitely means worse. But what if we had a statement? Instead of saying interacting with daughter at bedside, it could say, client yells at daughter, quote, who are you and why am I here? Right? And maybe we'd look at that and we'd say, okay, that's definitely not improved. Right? Hopefully that makes sense. Okay, if I went too far into the weeds, don't worry too much. My point being there's a level of precision that we need on the NCLEX, but as is, I think it's a pretty good item for discussion for low stakes. For high stakes, if it went all the way onto the exam, we'd probably see some changes in these last two choices. We might even see the deletion of that middle column, no change. With that, some of you, right? Some of you had fun doing this activity, so much so that I'm going to say, next step for you, come to Chicago in person or virtually and write real case studies for the next generation NCLEX. You can scan this code, or I'll give you a link you can just click later on, okay? But we would love to have you. We have had a lot of educators from Virginia. We would be thrilled to have more. So, one of the pitches I'll make too. Remember that case study, right? Well, the one we just looked at, or the one with the splenic laceration, right? Maybe you are the school nurse and you say, gosh, how do I know there's something with a school nurse? Jason said they could have it, but do they? Well, gosh, come to Chicago, write us a case study with the school nurse, right? Something to know is when educators come to Chicago to write case studies or any items for the NCLEX, we give them a lot of latitude. So they're tending to write from their experience, from what they know well, right? If no school nurses ever come to write for next generation NCLEX, it's going to be a little harder for us to have that setting. We're still going to measure our 6 skills, right? So from a measurement perspective, the test is just as valid, right? But from your perspective, you might like it better if there were more variety. Well, come to the workshop, participate, bring us the variety that you'd like to see. Okay, we've just covered the case study in tremendous detail, and I mentioned, of course, that to me, it's the single biggest change coming. It's the thing I want you to understand the most. I apologize if I overdid it, and then I'm going to make up for it by going really fast through all the other things that we care about. So we have more ways to measure clinical judgment, not just the case study. We have 2 other item types you may have heard of called trend items and bow tie items. We've got, as always, a newsletter giving you a lot of detail on those. These are not case studies. These are not 6 items in a row all together with the same scenario. These are individual items, and we use the word standalone as a synonym for individual items. Let's take a look at each. We'll start with the sample trend item. Trend item, what is it? Well, kind of like the case study, we've got split screen, left half, lots of information, right half, a question. Trend item, key feature, information that changes over time. You can see that here, 10 o'clock, 2 p.m., 6 p.m., right? Information that changes over time. That's it. That's the key feature of a trend item. And then we simply ask a question. Now, I did mention every new clinical judgment item being added to the exam goes back to those 6 boxes. So let's at least look at that here. Which of the following diagnostic procedures should the nurse anticipate that the physician would order? Well, that's kind of like generate solutions, right? What things might help this client? That's one of the ways to think about it. Barium enema? Maybe, right? Okay, all right, extra credit for Jason if I pull this one off. Esophagogastroduodenoscopy? Maybe. I think that might have been the best I've ever done on that one. I was sure that was a typo when I first saw this thing. I was like, no, too many letters. Anyways, okay, EGD, we'll call it EGD, but you get the idea. So this is pointing back to generate solutions. I have colleagues that like to emphasize as well that in order to get it right, your grad is going to need to recognize cues, analyze cues, possibly prioritize hypotheses, et cetera. In other words, it may indirectly hit those earlier boxes as well. But I would say the direct hit is going to be with generate solutions. Let's look at the bow tie item. The screen in the testing center is a little bigger than mine, so I've kind of crammed the space a little. It has room to breathe on the real exam. But the point is information on the left-hand side. What makes a bow tie item? Well, it's a drag and drop item where you drag and drop into this area that looks kind of like a bow tie. Again, based on your age, Young Sheldon, Pee Wee Herman, Bill Nye the Science Guy, or Urkel, take your pick. So a few things to know about the bow tie item. You see these headings, right? Not just on the bow tie targets, but on the token lists themselves, actions, potential conditions, parameters to monitor. Those are the headings for every bow tie item, right? We could have been imaginative and had a whole bunch of different kinds of bow ties. They're all like this: actions, conditions, parameters. What else? The bow tie. The bow tie itself, it has two things, then one thing, then two things. 2, 1, 2, they're all like that. It's always 2, 1, 2. The answer choices, you see 5 things, then 4 things, then 5 things. Guess what? They're all like that. 5, 4, 5. Okay? So, not a ton of variety there. What changes? Well, the scenario, right? The information on the left is what changes. And of course, the answer choices themselves, right? They're not all Bell's palsy, hypoglycemia, ischemic, I don't know, that kind of stroke, UTI, right? A little tip, by the way, in case you're wondering, because you might look at this and say, well, if it were me, I would love to answer the middle of the bow tie first, and then think about the actions, and then think about the parameters. And yes, the computer lets you do that, right? So it's common sometimes to think, oh, we need to go left to right. No, 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 no. Probably more logical to start in the middle of the bow tie. So that's a little bit of a tip, is that yes, that is allowed. Okay, bow tie. What are we measuring here? Well, remember we had a box called take action, direct hit, right? Direct hit. Potential condition. Well, that's prioritizing hypotheses. What do we think might be happening here, right? That's box 3. Parameters to monitor. It doesn't say evaluate, but it's a lot like evaluate outcomes, box 6. And again, to get it right, you've probably had to recognize and analyze cues, etc. Okay. So again, going back to those 6 boxes. With that, I'm going to take a sip of water. You can take a deep breath. We have covered the content, and we're now ready to look at how it all fits together into an exam. This is our thickest Next Generation NCLEX newsletter, Winter 2022, on test design. Test design is just our fancy phrase for what does the test look like? How does it all fit together? I'm going to give you a visual, then I'm going to give you a chart. We always have fun with this. You're going to remember this. We're going to pretend today's NCLEX is a cheese pizza, and then stop me if you've heard this one before. If it really were a cheese pizza, your grads would like it better and finish faster. But still, let's pretend today's NCLEX is a cheese pizza. What is the Next Generation NCLEX? Is it spaghetti? Is it a hamburger? Is it grilled salmon? In other words, is it totally different? Oh my God, they changed everything. No, it is a cheese pizza with some toppings. That's it. That's the Next Generation NCLEX. Cheese pizza with some toppings. The overwhelming majority of items that your grads will see on the Next Generation NCLEX came directly from today's exam. They're literally today's test with some extra items or case studies on top. So you're interested in that pepperoni, right? You're interested in the new stuff, but don't forget the overwhelming majority of the exam is today's NCLEX. It's the old stuff. We don't like to call it the old stuff, but you get the idea. The classic. It's classic NCLEX. How about that? Okay, let's look at it in chart form. So the test is changing a little, and the little ways it's changing are really important, right? We don't want to minimize that, but in a lot of ways it's staying the same, and we don't want to forget that. Timing, staying the same. Delivery, if you know about computer adaptive testing, we use it today, we're going to use it tomorrow. Number of items, here we see a change. Today's NCLEX, 75 to 145 items. This is RN and it's PN. This whole chart applies to RN and PN equally. What's it going to for next gen? Well, it's going up a little bit, 85 to 150. Not a gigantic change, but it's going up a little bit. You may know today that 15 of the items don't count. Why would we have items that don't count? We need to collect data to figure out, would this be a good item to use next year or the year after? We need to collect data. It doesn't count for your grads, but it's important to us to look at that data and say, oh, this item's terrific, or, ooh, this item's a disaster. Let's get rid of it, right? Okay, so there's 15 that don't count. We'll do the math. We'll take those away. Next Generation NCLEX then has 70 to 135 items that count for your grads. And we are going to precisely come up with what those 70 to 135 items are. 18 of them come from 3 case studies. Every grad, every candidate gets 3 case studies that count, right? Is the whole test case studies? No, there's only 3 case studies that count. That's how many everybody gets. So what about what's left over? If we take away the 18 items from the 3 case studies, we now have 52 to 117 items left over that count. Well, about 10% of those are those other clinical judgment items, bow tie and trend. So what about the other 90% of those? Well, that is classic NCLEX. That is the cheese pizza. 90% of that number or that range is the cheese pizza. Okay, so this chart, you'll have this, right? The test design newsletter goes into even more detail. It tells you things like, hey, out of those items that count, out of those first 52, now let's go with 70. Out of those first 70 items, that opening block to the test, 1 case study that counts is in the first third, 1's in the second third or the middle, 1's in the third third or sort of the end, right? So that test design newsletter will give you more detail, but fundamentally, here's how the test breaks down. Mostly cheese pizza, mostly classic NCLEX, but we've added 3 case studies, and out of the non-case studies, about 10% is clinical judgment bow tie trend items. Okay, 15 items that don't count. I just need to tell you one thing. It would be tempting for you to tell your students, okay, everyone, you're going to see 3 case studies. And then somebody comes back and says, I saw 4. Somebody lied to us, or the computer didn't work. Who do I sue, right? We don't want any of that. We don't want any trouble here at NCSBN. No. So it's important to know that the 15 items that don't count can include case studies, can include bow tie and trend items. Meaning, if somebody comes back and says, I got 4 case studies, you know that 3 of them counted and 1 of them did not. So no reason to panic, no reason to call legal counsel. But the point is, it's possible to get 4 case studies. It's even possible, very unlikely, but possible to get 5 case studies. However, only 3 of them count. Okay. With that final topic of the day, we're going to go interactive again. And Randall, I may depend on you when we get to the chat portion once again. Scoring. We've got a newsletter,
Jason,
yes.
Jason, I'm sorry. We did have one question that popped up that said, do the case studies end at 70 items or do they get pushed back by the CAT items?
Oh, really, really excellent question. Okay, so I'm going to actually not focus on 70. I'm going to focus on 85, right? Because from the candidate's perspective, they're looking at 85 items as part of that minimum length exam. They don't know which ones count and which ones don't. After that 85th item, there will never be another case study. They do end. By item 85, you've seen your last case study. Now, by item 70, you maybe haven't, right? Because after item 70, potentially, we still have 15 more items where you could find a case study, potentially even 2, I suppose. But yeah, after item 85, no case studies, whether they count or not, just no case studies after that first 85 item block. Great question. Okay, scoring. Because I like to go a little faster here, because I know how much time I eat up on everything else, I'm going to use sort of fun, localized Virginia examples that aren't nursing. And you're going to think, gosh, I would have loved to learn about scoring with nursing examples. Well, we've got a newsletter for you. It's really, really good. So we'll use my non-nursing examples to get through it a little quicker. But I'm going to quiz you on this and use nursing examples in the quiz. Anyways, new approach to scoring. Here's what you need to know. Today's NCLEX, you either get it right or wrong. Even select all that apply. You maybe know this. Select all that apply item. Pretend it has 6 choices. 4 of them are correct answers, and your grad chooses 3 of the 4. Well, that's pretty good, but we give them a 0, right? It's either right or wrong. Perfect or 0. That's essentially today's NCLEX. Okay. Well, next generation NCLEX, we're introducing a change to the scoring. We are allowing for partial credit, meaning that same person that got 3 out of 4 isn't going to get a 0 anymore. They're going to do better than that. They're not going to get full credit, right? But they're going to get some points. So this is a little complicated because we have 3 different ways to assign partial credit. I'm going to show you all 3. So Virginia is the birthplace of presidents. 8, I believe, in all have been born in Virginia, sorry, but we're going to keep it a little more brief here. The most common partial credit scoring method that we will use, including on all select all that apply items. And by the way, this is really important, not just clinical judgment, case study, select all that apply, all select all that apply, even from today's cheese pizza, right? Today's NCLEX, select all that apply, starting in April, you can get partial credit. All select all that apply, plus minus scoring. It's our most common method of scoring with partial credit. Let's look at the question. Which of these U.S. presidents was born in Virginia? Select all that apply. You may know the answers here. Well, of the choices I've given, oh my gosh, I put Abraham Lincoln. That's totally wrong. I might have to update my slide. Oh, panic has set in. I know it's not Abraham Lincoln, I promise. Okay, you may know the answers are James Madison, Thomas Jefferson, and George Washington. Oh, I'm so embarrassed. But anyways, forget the pictures. We'll just pretend they're not there. Let's pretend that somebody like me goes with these guys instead, right? Well, they got it a little bit right, but it's not perfect. How does plus minus scoring look at that? It says, we're going to give you a plus for anything you got right, and we'll give you a minus for something you chose that's not right. Total score, 2 minus 1, right? 2 minus 1. Now, a perfect response would have been 3 whole points, right? So this is 1 out of 3, right? That may not sound fantastic, but the point is it's not 0. Couple things I want to say about this approach. I'm still embarrassed I did the Abraham Lincoln, but anyways, that's okay. These things happen. All right. You could imagine mathematically ending up with negative points. Mathematically, if you chose nothing correct and you chose 1 or 2 wrong ones, you'd actually get negative, but we don't do that. So the second bullet tells you the story. If somebody got a negative, the computer rounds it up to 0. Okay, you can't get negative points on anything on the NCLEX. 0 is the lowest we would go. But more likely, right, if you get something a little bit right, you're going to get a point. Okay, now why do we build in a penalty? Because that might seem unfair or mean. Well, the reason we do is in a select all that apply, if there were no penalty, there would be a very, very lucrative test-taking strategy, which is check off every single box. Think about that for a second. If you check off every single box and there's no penalty, you're going to get all the right answers and not lose any points for your other stuff. You would get full credit every time just by checking off all the boxes. So whenever you can check off everything, we have to build in the penalty. It's not to be mean. It's so that we can accurately measure what you know. All right. Second most common scoring method is coming next. The question will look almost identical. This time, though, it says which 3 of these presidents were born in Virginia, and the computer will not let you check off all the boxes. It will not let you check off more than 3. So good news. Yeah.
I'm sorry, question that came in is said, if a student didn't select the correct option, would there be 0 point for that, or would there be a -1 for selecting, for not selecting a correct option?
Okay, so I think I'm understanding the question, and maybe here it applies if we look at George Washington. So George Washington wasn't selected. We don't need to do a -1 because the truth is, in a way, they already failed to get that point, right? Had they included George Washington, we'd be looking at 3 minus 1 equals 2. Because George Washington was omitted, they're looking at 2 minus 1 equals 1. So Yeah, I agree. When I first saw this, I was like, do we want to give them a negative one for missing George Washington? But in a way, they would lose 2 points if we did that. So it kind of takes care of itself. That's probably a bad explanation. But the point is, they're already losing a point on George Washington without us explicitly having to do any math. It just happened because they didn't choose him. They already lost that point. Okay, so in this example where you can only check off 3, if the same response is made, we don't need the penalty anymore. So there we go. They end up actually getting a better score, even though it's the same question largely and the same response. In this case, it would be 2 out of 3. It's probably what your student or grad would feel like they deserved on the question, right? No need for the penalty because they weren't allowed to check off every single thing. Third method, this is the most complicated. It's used the least, and I would encourage looking at our scoring newsletter to really get a good nursing picture of it. But I'll keep it kind of simple here. We'll do some geography, right? And we use rationale scoring when we're testing reasoning or relationships or rationales. In this case, a relationship. Well, if somebody thought the capital of New Mexico was Richmond, if you were feeling really generous, you might look at that and go, well, they're half right, right? Uh, you know, they're half right because Virginia Richmond is right and they did New Mexico Richmond, right? But if we're saying, hold on, we're trying to test if they know this relationship, they're not half right, right? It's just wrong. It's just wrong. So the point is, for certain items where the focus is reasoning or relationships, we might clump different parts of a response into a single scoreable unit, and in this case, decide that they just get it wrong. They get 0 out of 1 here. Nursing example. Let's say the nurse should question the order for medication X because something else, right? If we're focused on the reasoning and they guess the right medication but give us the wrong reason, again, generously, we might say, well, they got 1 out of 2. But if we say, hold on, we're looking for the reasoning. That's what we're trying to measure. We'd have to, if we're honest with ourselves, we'd say that reasoning is not evident at all from this response. Therefore, 0 out of 1. Again, the newsletter will be very good with nursing examples. All right, we'll quickly take a look at the benefits. I'm just going to go very fast here and indicate when we score everything as either right or wrong, you get a point or you get nothing. We're essentially dividing the candidate population into 2 groups, and these groups are very big, and within each group, there's a lot of variance. I'll give an example. Let's look at this group of students who earned 1 point on an item. Well, the person in the blue skirt just barely knew enough to get the point. The person in the green skirt knows everything. Well, they're pretty different. Their ability levels are very different. Wouldn't it be great if we could distinguish them better in the way we score the item? Well, that's what partial credit scoring does for us. We can now divide our candidates into these smaller groups where the people in them are a little more alike in terms of their demonstrated knowledge, skills, and abilities. So under the hood, we get much better measurement information. That's why we do it at NCSBN, but there are some side benefits as well. I think as educators, you look at how complicated some of this stuff is and you say, yeah, that seems more appropriate, that you can earn some points even if you get a little piece wrong, and probably your students would feel like it's more fair. We're going to try a couple together really quick. This is from that first case study that we looked at. It's the analyze cues item. We're going to pretend you don't need to remember the scenario. We're only focused on scoring. We're going to pretend somebody checks off almost every box, and we're going to pretend that 3 were correct and 2 were incorrect. Go ahead and type in the chat, Randall. Let me know what you see. What score should I give this person? What score should I give this person?
We're coming up with 1.
Okay, you're seeing a lot of 1s. 1 is correct. First question I ask myself is, are they allowed to check off every box? Yes. Select all that apply. They're allowed to check off every box. Therefore, we have to have a penalty. 3 minus 2, we get 1. Great job. There we go. All right, this next one, I'm going to warn everybody, is very tricky. Almost nobody gets this one correct. I'm not trying to scare you. I'm just saying you may have to really think hard. You might even say it's unfair of me to put it on the quiz. But okay, let's try this one. This came from the Egyptians. Let's pretend that somebody decides 7 out of 8 are anticipated. Well, and in real life, here's what we've got, right? What score do we think this candidate would earn? Go ahead and type it in. I might have scared you against typing because I'm telling you, it is a little tricky. But Randall, let me know if you see anything come in.
I'm getting all zeros.
You're getting all zeros. Okay. Well, this one certainly is tricky because if you've given it a 0, it's because you're saying, well, I need to build in the penalty, right? So I'm going to do some subtraction here. I'm going to get a negative number and I'm going to round it to 0. I did outsmart Jason. I did remember to round it up to 0. He said it was tricky, but I got it. Ooh, not so fast. Can we check off every single thing here? Well, that's the guiding question that helps us determine whether there's a penalty. On one level, you might say, yeah, it feels like it. I checked off something for all 8 choices. Truth is, what would checking off everything look like here? It would look like checking off all 16 bubbles, right? If we really wanted to cover our bases and try to outsmart the system, we would have to check off all 16 bubbles. The computer won't let you do that. It will only let you choose 1 bubble per row. Therefore, no penalty needed. I know it's a tricky one. Maybe with my explanation, it made a little more sense. So in fact, it's a 3-point response. Final one, it's the evaluate outcomes. We can click on any of these sentences. This person went with this one, and this one. One of them's wrong, one of them's right. The last one's wrong as well. How about the score for this person? Think hard. Do we build in a penalty, for example? Let me know what you see.
I see 1.
You see 1. Okay, do we see anything else?
I got a 0.
Okay, all right. The usual responses I see are 1, 0, and -1. What's the answer here? Well, somebody could click everything. They could click everything. So we have to build in the penalty. So we're looking at 1 minus 2, which gets us to -1, and we round up to 0. This is a hard quiz because I taught you everything you needed to know super fast and actually gave you some pretty tricky ones. Right answer here ends up as 0. With that, some quick things. Newsletters, I've mentioned these. Great source for anything where I went too fast or, scoring, great example. I went super fast. Avail yourself of our newsletters. Sample questions. We have a new website, nextgennurses.org. It is an NCSBN, totally legit website. It's us. It really is us. Sample questions, case studies, bow tie items, trend items. And if you want to see how they sit in the exam alongside multiple choice, select all that apply, classic NCLEX, how it all mixes together, then you can download the even bigger PDF that isn't just case studies, bow ties, and trend items, but it has like 100 or so classic NCLEX items interspersed. I mentioned computer adaptive testing. I've got a short video on that if you'd like a refresher or an introduction. So that's a great resource. What else? Updates. The test plans that govern Next Gen NCLEX are available now. I'll give you the link. Passing standards, if you follow any of that news. Often, every 3 years, the passing standard goes up a little, which in theory makes it a little harder to pass the exam for a bit, right? You have to know more, you have to do better. Well, the board of directors met last month and determined that the passing standards would remain the same. They did not nudge upward at all. They are staying the same. Same thing that they've been for the last 3-year cycle will govern the next 3-year cycle. Small change to the RN test plan, management of care going down 2%, safety infection control, pharmacological therapies, each going up 1%, PN staying the same. Now, the test plan document is an essential. Don't just look at my chart and say, oh, PN's staying the same. I don't even need to bother with the test plan. No, because the test plan doesn't just give you these numbers, but it talks you through what content is eligible. And that can change from cycle to cycle. When you download these slides, you'll have all these resource links, how to sign up for writing panels, where to find all the newsletters, how to get those sample items I briefly pointed you to, test plans, etc. So if you're high tech and want to scan this QR code, you'll be able to download the slide deck. I'm going to type the link into our Q&A chat as soon as I exit here, because you may just want to click directly either way. And then I'm always available for questions because I am famous for, we hang up, right? You had a chance to ask your question, you walk away, and then you go, oh, that's what I should have asked, right? Well, you got my email address now.